is a 75-year-old patient with newly diagnosed myeloma, clearly needs therapy. She's fit because she has no comorbidities, has a good performance status, has an active life. So probably the first choice for a patient like this would be a triplet with Revlimid, Velcade, and dexamethasone. That is what at this point is the most common induction regimen that is used. However, the field is rapidly changing because new data has emerged from Europe and also here, showing that when you combine these 4 drugs, you add daratumumab to VRD, you get actually better responses. So that is a regimen that is still not FDA approved. So it may not be really available or feasible to give it to a patient. But definitely would be an option. So I think at this point, probably first option would be Revlimid, Velcade, and dexamethasone. If you are able to add the daratumumab, then that would be good. Another option in this patient, given that she's an older patient, would be to give her Revlimid, daratumumab, dexamethasone. That regimen currently is approved for patients that are non-transplant candidates, but in reality, it's a very effective regimen, inducing 48% complete remissions. So I think that would also be a suitable option for this patient if for any reason she cannot tolerate the Velcade. We have learned over the years that maintenance is very important. There are 2 big randomized trials showing that lenalidomide prolonged progression-free survival and also overall survival when you use it as maintenance therapy post-transplant. There are other studies ongoing looking at other combinations, including lenalidomide with daratumumab or lenalidomide with Velcade. Right now, the biggest challenge treating myeloma patients is the high-risk patient population. These patients, fortunately, they're only 15% of newly diagnosed myeloma patients, but it seems that no matter what treatment we give them, they still have a poorer survival. So we frequently consider other treatments for maintenance that are not just lenalidomide. So in practice, we usually use a combination like a doublet for patients that have high-risk myeloma. The GRIFFIN study is a study that recently completed accrual, and it's a study that included patients that were younger than 70 years old and were newly diagnosed untreated myeloma, and they were considered transplant eligible. The study first had a run-in for safety of 16 patients. The treatment schema was that the patients were to receive lenalidomide, bortezomib, and dexamethasone with daratumumab for 4 cycles, followed by consolidation with transplant, and followed by 2 more cycles of the same induction regimen, and then followed by maintenance with daratumumab and lenalidomide. And this safety cohort includes 16 patients. The response rate was 100%. And actually, after consolidation, about 63% of the patients were in complete remission. So based on this, really good data, a randomized study was designed looking at this quadruplet combination compared to lenalidomide, bortezomib, and dexamethasone without the daratumumab. And about a little bit over 200 patients were randomized in this study, and accrual has been completed, and the initial data is consistent with those, the data from those initial 16 patients, showing that you get a higher number of patients achieving stringent complete remission with the quadruplet, 42% versus 32%. The overall response rate is also higher. However, the important point is that we get deeper responses when we add the daratumumab. Also, about 50% of these patients were minimal residual disease negative. The CASSIOPEIA study is a study that was conducted in Europe, and it was for newly diagnosed myeloma patients untreated that were considered transplant eligible. So these patients had to be younger than 65, younger or equal to 65. They had to have newly diagnosed myeloma that was untreated, and about 1,000 patients were enrolled in this study. So patients were randomized to receive bortezomib, thalidomide, dexamethasone, and daratumumab versus bortezomib, thalidomide, and dexamethasone. Patients were to receive 4 cycles of induction therapy, followed by consolidation of transplant, followed by 2 more cycles of the induction therapy. And then patients were randomized to receive either daratumumab or observation as maintenance therapy.